Hi, it's Chris. Welcome back to Basic EKG Interpretation for Healthcare Providers. We're going to get into Chapter 7, Ventricular Rhythms. So remember your 5 rules and ventricular rhythms. All right, so what is that? We're going to have stimulus that are originating in the ventricles, right? So you can see by the obvious arrow there, and we distinguish ventricular rhythms by the QRS complex width. So you do need to go through your 5 rules. There are a few other criteria that we want to look at in identifying the varying types of ventricular rhythms. So let's do it. Let's get into it. Your first one that we're going to discuss is the premature ventricular contraction. Similar to what we discussed in the previous couple of chapters with the PACs, atrial contractions, and the PJCs, junctional contractions. These are a little bit more concerning than those, just because irritable foci coming from the ventricles that are happening frequently can be dangerous. It can they tend to be more associated with poor outcomes if they are occurring quite frequently. So watch out for those PVCs. All right, so let's go through our 5 rules and measure our rate and regularity. So you can see we've got a couple of measurements so far that are identical, and then we have 3 more that are identical. So it looks like we have an underlying rhythm that is sinus, right? So we see these upright P waves with identical morphology going across. And then it looks like the reason that we have these wide measurements here is because of this premature ventricular contraction. All right, so let's do some more measurements. Measuring our PR intervals, they're within 0.12 to 0.20, so that indicates that we have a sinus rhythm because all of those are the same going across. If we measure these, they're all the same. All right, so our PR intervals indicate we have a sinus rhythm, but we do have these other contractions that are very wide, and that's how we identify them as ventricular in nature. All right, so you can see we've got a QRS complex with measurement there in our underlying rhythm that is normal, but our PVCs are wide. So we call this sinus with PVCs. All right, and again, it is sinus because it is in between 60 and 100 as far as that underlying rhythm goes. All right. Note that compensatory pause after the PVC. Just want to identify that. That is a good thing. The heart is taking a little bit of time to get back to its normal rate, so to speak. All right. So moving on to the next one is an idioventricular rhythm. Again, idioventricular indicates that we are originating in the ventricle. You're going to get speeds of 20 to 40 here. We're getting into the dangerous stuff now. So this is a rhythm that is often associated with a patient who's unconscious, unresponsive, and many times does not have a palpable pulse. Um, so let's look at our 5 rules. And so first we measure the regularity. Is it regular? Yes, it is. Those are all spaced evenly apart and about 38 small boxes in between those. So that gives us a speed of 39, putting us in that idioventricular rhythm range of 20 to 40. There's no P waves there, so you can't measure a PR interval, and our QRS width is quite wide. It looks like it's about 2 large boxes wide. All right, so we call this an idioventricular rhythm. So when we get into the next one, which is called accelerated idioventricular rhythm, we're talking about speeds of 40 to 100. So not tachycardia, but faster than what we would expect with an idioventricular rhythm. All right, so let's go through our 5 rules and measure our regularity. This is regular. Our our intervals, or in this case, these are all S waves. So you just pick the same point on each one. So you can see this. I'm picking the same point on each one of these with our calipers, and they all measure the same, about 21 boxes apart. So we have a rate of 71. So it's regular. There's no P waves, therefore we cannot measure a PR interval. We do have so another measurement there of the regularity. We do have a wide complex QRS width. I'm getting 0.16 apart. So looking at a few of those measurements, and I tightened up this one a little bit closer. I just wanted to kind of point out the way that you measure the end is you have your change of direction up here. So your change of direction is occurring where this top caliper is kind of pointing down there. All right, sometimes it's a little confusing, but that is essentially what we call a J point, where the QRS complex ends and the ST segment begins. And so we have a wide QRS complex there. And so with our 5 rules put together, we call this an accelerated idioventricular rhythm. Again, just a reminder, it is not tachycardia until we get faster than 100. So let's take a look at tachycardia. So with our 5 rules, starting with this one, ventricular tachycardia is one of those that's it's pretty easy to spot from across the room. All of those QRS complexes that you're seeing are pretty obviously wide, and they're all the same shape. They're the same morphology. All right, but let's go through our 5 rules. Keep up with good habits, and so you can see the regularity there is the same. You got about 7 small boxes apart, giving us a speed of about 215. So it is regular. There's no P waves there, therefore there's no PR interval to measure, and our QRS width is 0.2 seconds. All right, and so how did I get that? All right, you can kind of see over here where I'm putting the cursor, you can see that little change of direction there. That's where our QRS complex starts. And again, the QRS complex is ending at this change of direction up here. So you can see with this next one there, it's approximately 5 small boxes apart, giving us a wide QRS complex. And so we call it ventricular tachycardia. All right, now you get into ventricular fibrillation. Good news with these, they're very easy to spot. The bad news is you're doing CPR and medication administration for these patients, trying to get an organized rhythm on that rhythm strip as best you can. So the top one is commonly recognized as coarse VFib if those fluctuations are greater than 5 millimeters. So this is very coarse. You know, if it's greater than one of these big boxes, and over here you can see this is fine. So identifying that one as a fine ventricular fibrillation, you're going to treat both of them the same way. This person needs to be defibrillated and have high quality CPR put in place. But you can't measure the rate. It's very much irregular. There's no P waves or PR interval or QRS width consistent to measure. So it's ventricular fibrillation. All right, and then we get into torsades de pointe. It's a form of polymorphic ventricular tachycardia. And so the way that you distinguish torsades is the word comes from French meaning twisting on a point. So you can see this person had looks like a somewhat regular rhythm here, and they went into torsades. So you can see you have this varying morphologies of ventricular tachycardia, and then it comes into this little point here and gets twisted and then starts getting bigger. So we call that torsades de pointe. And going through our rules, you can see that it is a regular rhythm, but you do have varying morphologies with those QRS complexes. There's no P waves to measure, no PR interval, and the QRS widths do tend to vary a little bit with the different morphology. So we can call this polymorphic ventricular tachycardia, but it's common to call this torsades de pointe. All right. Very quickly, a common reason, the most common reason why someone goes into torsades is because they have a long QT interval, and that's what it looks like happened here. When you hear the phrase R on T phenomenon, it indicates that this R wave here occurred early. Remember those absolute and relative refractory periods I was telling you about a few chapters ago? This is a very dangerous portion of the EKG complex. So if a rhythm, if a stimulus occurs too early, it can cause a person to go into this lethal rhythm. And it's important for you to know that as you progress in this business, because there are certain medications that can elongate the QT, and you have to be careful about administering those to someone that has a pre-existing long QT interval. So we'll talk about that a little bit more when we get into 12 lead. But that's it for chapter 7 in ventricular rhythms. Thank you.